Welcome back, everyone. Hope you had a nice break. I loved the first two sessions. Hope you did, and really looking forward to session 3, Frontline Healthcare Professionals. So take it away. Thanks.
Thank you, Ellen, and welcome back. We have 4 very interesting guest speakers, and I'm going to introduce them all first, and then we'll hear from them about their experiences on the front lines of the pandemic. So down at the end there, Travis Beach is a lieutenant and a paramedic with the Poulsbo Fire Department, tactical medic team lead, and I'm pronouncing this right, Kitsap County Sheriff's Office, and also an operations officer with an HHS incident management team. Lots of titles. I hope I got them mostly right. To my left is Dr. Nader Kamangar, who is a professor of medicine with the David Geffen School of Medicine at UCLA, chief of the Division of Pulmonary and Critical Care, vice chair, Department of Medicine, chief of staff, all of View-UCLA Medical Center. And then to my right here, Taryn Amberson, who is an emergency nurse, editor fellow with the Journal of Emergency Nursing. And on the end, Gabriel Felix, who is a captain with the Los Angeles Fire Department and a paramedic. Thank you all for being here. And first, I'd just like to, go down the line and have, each of you, starting with you, Travis, just describe, put our audience where you have been in dealing with the COVID pandemic. What has it looked like from where you've been and what you have done?
Sure, thank you. And I would like to lead off by, number one, really appreciating the people that went before me. It's very interesting, this change of gears, getting perspective on the emergency provider side of the house, hearing the stories from the people that had suffered through and still working through some of that COVID really resonates with me, and it's so profound, and my thoughts are with you, because for me, as an emergency provider, most of the time, my time with you or the patient is very limited. I come in, I make a very quick connection with you, I meet your needs, and then I turn them over to my other healthcare professionals that I sit with up here. But I just wanted to extend my thoughts to you, because I think it's great what you're doing, the courage for you to speak up. So keep it up. A little bit about myself and my world. As an emergency provider, a lieutenant paramedic for what I would call a small fire department in the Pacific Northwest. I'll try and avoid some of the dynamics between state to state philosophies on how they dealt with COVID. But as an individual, one of the biggest things that I can attest to, and probably some of my professionals that are in the room, is we're very much a team-focused organization. And COVID really invaded the team atmosphere, in my opinion. We had an administrator that is responsible for protecting us, maintaining our health and wellness, and most importantly, trying to prevent an entire shift, 30 people going out sick at one time. The implications of that is insurmountable. And so, doing risk management as an administrator, we were forced into different types of working atmospheres that didn't necessarily limit our service to our community members, but it tore away at our team atmosphere. And that's something that these people that I work with every third day, I spend a third of my life with these individuals. They are my family. I depend on them. My life is in their hands and theirs in mine. And so personally, from this perspective, in the field, it was very difficult, and in some cases still, in a limited capacity, very difficult for us as a team to continue to do that team building, to learn to rely on each other, and connect on that daily basis.
Okay, thank you. Nader, you've been, running a whole department, right? And a whole, you've been really at the high level, at the center of things in LA.
Right. Well, thank you, everyone, and thank you for being here and taking an interest in this program. Dr. Sachs, thanks for putting this together, and Chris and Layla for coordinating everything. Thank you so much to all the speakers. Yes, at heart, I'm a clinician, and even though I'm responsible for division and all the things that go into putting a group of providers together to meet our patient needs, at heart, I'm a clinician, and this pandemic provided a very unique experience, one that I'd never gone through before. I mean, as intensive care unit physicians, we take pride in creating calm out of chaotic situations, putting our own wellness and emotional well-being to the side and dealing with, end of life often, as is the case in the ICU, and helping our patients in every way we can. And, my experience, in many ways, these past 2 years have been a fog. There have been so many different phases. But at the very beginning, there was the unknown, and trying to kind of reassure the providers, reassure my colleagues, the nurses, the respiratory therapists, that we would work together and get through this, even though at the very beginning, as you all know, we were, there was issues with limitations of PPE. And at the very beginning, we were using the same N95 mask, and we were putting it in these Ziploc bags and reusing them. So we've gone through various stages. Obviously, that's no longer, fortunately, a problem. But a lot of it, I felt like I had to care for patients, but also care for my colleagues. Unlike Travis's experience, one of the things that got us through this very dark and difficult period was the unity that we had within our group in the ICU, and we were our own support structure. Really, we did not receive any type of emotional support from the institution or our colleagues outside, especially at the very beginning, because, as many of you know, people were very frightened. And at the first 3 months after the pandemic started, you couldn't see a provider come near the ICU unless it was an intensive care specialist, obviously the ER docs, the hospitalists that were taking care of patients outside the ICU. So there was this sense of togetherness and being able to work together. And certainly during the surges, the different peaks that we had, I work in a teaching hospital where we have medical students, residents, fellows who are training to become specialists in critical care. And what we had to change the model, because at any one time we would have 30 patients with COVID on ventilators. And the same residents that would be at night taking care of those patients just did not have the ability to really meet our patients' needs. So we had to have two teams. Two of us attending physicians had to stay overnight, and we would be running from room to room to room, putting someone on a ventilator, putting a tube in somebody's chest, doing CPR on another, and it was very difficult seeing all this. It was difficult witnessing patients spending their last moments alone, having us or the nurse or a resident take an iPad into the room so that they could say their goodbyes to their loved ones. I mean, those images are indelible, and they will never leave me. And I was just telling some of my group, I still haven't really dealt with a lot of this yet. And neither of most of my colleagues. We talk amongst ourselves, but for the most part, none of us have sought any professional help. But as a group, we were able to feel one another. But when we would go home, as you all know, especially at the beginning, it was isolation. And it was very difficult to explain this, even to our loved ones, what we were seeing. It was virtually impossible to explain this to people. I remember during the first surge that we had, after working 48 hours, I'd go on a bike ride, and on an isolated road, and somebody nearly ran me down because I was biking without a mask on. So there was a lot of craziness out there as well, a lot of misinformation, a lot of things that we dealt with. I apologize, I'm kind of going all over the place, but it's been such a, heterogeneous experience at different phases, and I can go into each individually, but one thing I had to say from a mental health perspective that kept us together was the camaraderie, the cohesion, and the unity that we had as a group of healthcare providers, and we were there for one another. But outside of that, we really haven't gone and grieved and expressed ourselves to those really that could potentially provide us more expert assistance.
Oh, that's really interesting, and I think we can come back to a lot of that, what both of you said. Taryn, you've had, as an emergency nurse, in a couple of different locations during this, you've had some really challenging experiences, not getting the support that you needed at various times, right? Can you talk about that? What has your experience been like?
Sure. So I worked in the very beginning of the pandemic. I worked in a ER in Southern California, and then I want to say starting October 2020, I also worked in an ER, in a community ER in Hawaii on Oahu. So in the beginning of the pandemic, I wasn't in Southern California for any of the surges. It was still pretty low key. Nobody was coming in. I remember seeing 17 nurses and techs on our board for 3 patients. So it was kind of like that in the very beginning. Everybody was afraid to come in. And when I think about my experiences and I listen to my colleagues speaking, I think the first word that really just comes to my mind is grief. In experiencing the pandemic as a healthcare worker. And, there's the pain of not being able to deliver the level of care to your patients that you pledged to when you became, when I became a nurse, when I graduated, we took an oath. So there's that pain, the pain of seeing patients isolated from their families in moments of death and dying and moments of immense suffering. And then there's also some anger, which might be part of grief, when I think of, how healthcare facilities either did or did not resource us as frontline healthcare workers. And just, I think sometimes in disasters, you have like this period of romance where it's like, we're all in this together. Like, we're going to get through this together. We're going to get to the other side together. But that was not my experience. Even from the very beginning in California, it was the PPE was locked up. We were told what we were, we were not to have N95 masks in the beginning. We did not need them because that was our leadership's interpretation of research. So right off the bat, it was just very, there was the grief of not being able to give patients the support that they need, having to give loved ones their deceased spouses' belongings without letting them come in and say goodbye, and unexpected deaths. And then in Hawaii, that's when I experienced, the surges. And that's a very interesting practice environment because you're on an island, literally, and you can't pull on resources from neighboring states like you can on the mainland. So, we would surge, and there would be one ICU bed on the whole island, and no ventilators, and not enough staff. And you just show up to that every day. And then by the time the help would come, let's say they put in a request for FEMA to send nurses, those nurses come, but then the surge is already kind of over. So we've been really getting just killed as the surge goes up, and then the travelers come, and then the surge is going down, and then the organizations were force flexing staff because they couldn't afford to pay for them to stay. So it was just kind of both ends. You weren't getting what you needed, when it came to support at the bedside, when it came to your own personal mental health support as a clinician, and then just basic getting paid for the work that you do, you're still really not getting supported. So
It's a lot to deal with. Gabe, so, you know, what were you witnessing? I mean, you're
Mhm.
in this major city dealing with,
Yeah,
I'm
I
sure
would just want to
everything.
echo everything else on the board. Everyone said, you know, we were fortunate enough to have the N95 masks, so our department kind of pre-planned. So we had all the PPE available. Like Travis said, we are a family. I spend a third of my time with this family. So in my position, I am a paramedic captain for my battalion, which is Battalion 11 in the Pico Union area. Some of the most dense population isn't located in that area. So I'm in charge with the training of any EMS that comes out from the county. I have to push it out to our paramedics. All of a sudden, the department says we're experts on COVID. So I was responding to every possible COVID incident within the area, even including Hollywood down here in South Los Angeles. 20 to 30 calls a shift in a 24-hour period. So that stress kept on adding up for me, and then, you know, all of a sudden, family thinks you're the expert on COVID also. What about this? N95s, paper mask, what is it? I just didn't know. So dealing with my crews, trying to take care of them, make sure that they're mentally well. Hospitals were inundated, and they were waiting for beds sometimes for hours. These particular members didn't have lunch, they didn't have any dinner. So what I would do, I was nervous about going in the ER myself. Oh gosh, should I go in there? Okay, my crew is in there. Let me go get them some food at least. Hopefully you can get them some food. And then that way, sooner or later, they'll get a bed. So there came to a point where a lot of our resources were not available. So we're pulling resources from other areas. Like Taryn said, there was a lot of surges. In the beginning, we were hit very hard. And then it kind of died down. And then the second wave came where people were afraid to go to the hospital because they thought they were going to get it. So by this time, their illness had already progressed. So we went on lots of cardiac arrests. Tons of cardiac arrests were, unfortunately, we had to pronounce in the field. There was a policy that came out that we would do what we could, but the hospitals were inundated, so they did not want us to bring patients that were confirmed positive. So, and then another real quick backstory to this is I've been on the department for 22 years, and I've never seen more people attempt to hurt themselves than this particular period. So I'll just say that. So what I did is I reached out and I sought my own help. So I had a psychiatrist, psychologist that I speak to and I still currently speak to. So that has helped me a lot. And then with our camaraderie, what we do at the firehouse is we like to play games, whether it means working out, we play paddle tennis, if we have time though, but during that time there wasn't anything. So exercise is key for us. And I think just talking to each other, you know, hey, is everything okay? You have any issues at home? I think that was the best thing for us.
Well, thank you for sharing all of that. I wonder, you know, it's really interesting that you actually sought psychiatric help yourself.
Yes.
Can each of you, I don't know if each of you can speak to that, you know, what you've done to, you know, to try to help yourself. And I think also just, Gabe, one of the things you said about seeing other people, you know, harming themselves.
Yeah.
That's a dynamic that, you know, I think
It was really unbelievable. I couldn't believe how many people had harmed themselves during that period.
Okay.
Yeah, I'm happy to lead off with that question. As far as taking care of ourselves, our own personal wellness, just as Gabe's mentioned, in the fire service, we definitely do a great job of trying to give each other a hard time, and we deal a lot with our stress, our daily contacts and things that we're exposed to. We don't take home, so we leave it at work, and most of the time that's through humor, messing around with our team. The other thing that is profound in our organization and the fire service is fitness. On the job and off the job, we use that as an outlet to manage our stress levels. And unfortunately, that was another component to risk management from our administration is that they shut down that opportunity for us to connect with our team in a fitness environment. And so there's basically limiting our outlet, and that compounded the problem. And for me personally, I haven't gotten to a point where I need to seek out a professional for my personal wellness. I love the idea of actually just making that contact, so that way when you have it, you need it. I think that's great, and that's something that I'm going to follow through on. But our organization does have a wellness fitness team. They are internal people that have been trained, and you can contact them. It is under a code of silence. The speech that we share with these individuals is protected. It's not something that's going to be divulged to any administration, and so they are readily available to us. And I have personally reached out to them, sharing some of my frustrations and things that I've been feeling. Outside of that, I haven't done anything else.
Yeah, that's good that you at least have that outlet. Nader, a couple of things that you were saying that I thought might be relevant to this was, the way that you needed to kind of navigate things at home with family members who maybe didn't understand what was happening or maybe didn't understand the seriousness of COVID. And then just also, trying to keep so much compartmentalized as you're dealing with all of the different levels that you're having to deal with. If you can talk about both of those things.
I think I don't know if this is on still. Okay, so I think as all of us struggled, in my case, this happened to occur kind of in my middle ages, in my 50s. So naturally, that's a time of turmoil for married couples, especially if you've been married for 20 years or longer, as I've been. And it happened that I'm actually as intensivists, we're the least alarmist, we're calmest under chaos, and when actually things are calm, I tend to be more chaotic. But in this situation, I try to relay my concerns to those that I loved, and unfortunately, I had a lot of resistance, and certainly there was a lot of misinformation out there. There still is, that we all grappled with. But when the vaccines came around, I had that challenge of really, having been on the front lines in one of the busiest metropolitan areas dealing with COVID, and yet I couldn't convince my wife to get vaccinated. And I can't express to you, I can't ever say this to her, but how much that hurts. And just to see that, to see what my patients went through, and to really not have that awareness. I obviously have to respect individuals' autonomy. That's one of the first things we learn in medicine. But it was difficult. Those were very challenging, and dealing with a lot of misinformation. And if you don't mind, I'll just segue into, as we're talking about misinformation, as Taryn was describing, as the surges went on during our main large surge in December of 2020. What we noted is, people weren't, as Gabe said, people weren't coming in. People were, and when they would come in, they had heard that going on a ventilator was basically a bad thing, and most people that would end up on a ventilator would not make it. And so we would have to, there were cases where, we had young patients, 30-year-olds, that were on as much oxygen as we could humanly provide them for days and days. Our rational mind, and we would be telling them, we gotta put you on a ventilator, you're gonna potentially die, but they were too afraid. And we had to kind of combat that without their loved ones there to help us mediate that. Because this was discussed elegantly earlier in the sessions, there's a lot of delirium and a lot of psychosis that's there that we're grappling with, but at the same time, we don't have the mediators. We spent so many hours a day speaking to families and loved ones, and it was very difficult to really bond with family members when you're doing it over the phone as opposed to in person. So there was a lot of misinformation. There was a lot of patients coming in and saying, I'll only allow you to put my spouse on a ventilator if you give them ivermectin or if you give them Plaquenil. This is after all the data came out on Plaquenil. So there was a lot of frustrations, and I echo what Taryn said about anger. At times, there was a sense of anger that I felt among some of the staff where, we were, burnt out by this point, and patients, one after another, paramedics would go to a home and everyone would be ill. They would just bring the, father or the grandfather who was just severely hypoxic. They were already blue, but then they would be saying everybody else in the house is coughing and they're really, really ill. And it was just frustrating because we didn't have enough beds. We had converted areas that were non-ICU areas into intensive care units. And to know that these patients really could have done something to protect themselves and didn't was also frustrating. And for some people, it did cause some anger.
No, I can totally understand that. And, as a part of my job is trying to provide truthful information, having to fight against the tide of misinformation that seemed to be coming from all corners, it's still a battle. It's our core mission, really. Taryn, last night you and I were talking a lot about some of similar things. People who were reluctant to be vaccinated, and also something that I thought I think I asked you about was that the way that the public, or at least some segments of the public, their view of health providers and frontline workers changed over time. So there was sort of this hero narrative in the beginning, and you had, I thought, a very interesting reaction to that, and then how that changed to the point where people who were heading up public health departments were getting death threats. I mean, it's just kind of astounding the way that public perception has changed, and I'm guessing that has to be a critical part of what all of you have perceived in your lines of work. So, do you want to tackle any of that?
Sure, yeah, I can speak to my feelings about the hero narrative. I know that they absolutely didn't come from any place of ill intent from anyone by any means, but it just felt a little dehumanizing from the very beginning, because yes, we're making tremendous sacrifices. We don't know what this virus is, we don't understand it, but we're showing up every day for our communities, and that's a huge risk, right? It's a risk to our families and the loved ones that we live with. But it just seemed like we were doing that every day before the pandemic too. So rather than heroes, well, you're a healthcare hero and there's all this praise, when really, yes, what we do is heroic, but we're also just humans that have needs and are experiencing a lot of psychological distress and trauma. So to be portrayed as a hero and then to just feel your own humanity and the trauma that you're experiencing as a clinician, that you're sitting with your patients going through, it just felt like a very, there was just a lot of dissonance there for me. So that's, and then of course it changed over time. And so with the vaccine hesitancy on the island that I live on, I just have an interesting perspective. I have some family members that do not endorse the vaccine, and we try not to talk about it often. Maybe that'll change someday, but on the island that I live on, I am not a native Hawaiian. But I experienced a lot of patients coming in that identified as natives or various racial or ethnic groups and did not want to get vaccinated. And during some of the surges, we would just have lobbies full of patients that weren't vaccinated experiencing COVID symptoms. And so there was a really deep, I think, sense of anger and frustration from healthcare workers towards the community, a sense of betrayal almost. Like, we showed up in the very beginning for you guys when we didn't understand this, and you know, a lot of us died trying to help our communities. But now that there's a vaccine, you know, you don't want it, which is your ability to decide that for yourself, but you're also still coming to us for treatment. So you want treatment, but you want it on your terms, and it just felt, I think there was a deep sense of disrespect among my colleagues that was perceived in that. But I think it's also important to, when we're talking about vaccine hesitancy, to look at historical trauma in that, you know, on the island, that island belonged to a people group, and then the United States came, and now it's part of the United States. But the most healthy people on that island are not Native Hawaiians, and they actually have the least positive health outcomes out of every racial or ethnic group on the island. So there's some historical and very valid mistrust of different people groups that experience vaccine hesitancy different. And so it's just been interesting to be out of off of the mainland and experiencing that, because it really did give me a different perspective.
Yeah, really interesting. Gabe, and I wanted to sort of ask each of you, you know, if you could fix one thing, you know, about what we've all been through, about, you know, the system, or you know, the way people behaved, or anything. If you know, can you think of what you would do, what you would do differently?
Yes. Oops, sorry. Particularly here in Los Angeles County, I'm not sure if everybody knows. Recently, in the past few years, we've had a lot of hospitals close their doors. So that has very limited our ability to transport patients to facilities. And also, I think another key piece here is we really need more mental health facilities. A lot of the patients we are running on nowadays have mental health illness. And our department is very progressive. So we have a therapeutic van that, oh my God, sorry. That's run by the Department of Mental Health. So anytime we have a patient who we know is going to be a 5150, we request them. So they are 24 hours a day, so we're very progressive. So that is helping, where this van is able to transport these patients to, let's say, Exodus. And you are taking a fire resource and you put it back available for the community. So I'd say having more available hospitals within the region and more mental health facilities, I think, would be a great goal for the county in general.
Travis, do you have a thought about that?
Yes, certainly. If I was gonna, if we ever, and hopefully we don't, if we ever revisit something like this, hopefully we come to the table with a lot more information and data and facts, and try and avoid some of the misinformation that was put before us. But as far as something I would like to see differently, as far as managing it within my world, you know, again, it is about risk management. I can't imagine how difficult it is for my boss to think about how to best do that. And we have, I would definitely like to piggyback on what Gabe said. We do have mental health professionals now teaming up with the fire department to alleviate and, quite frankly, kind of redirect mental health intervention away from law enforcement. Our law enforcement entities locally, I love them. I work with them regularly. They're amazing people. But a lot of times they kind of find themselves bound up in an area that they're not really proficient at dealing with. And it created a lot of problems within my local. And thankfully, we have found some funding mechanisms to put mental health professionals in van with a fire service provider. Then that way we can do some basic evaluations if needed. It's an ongoing sustainable funding mechanism for us. So we do put these professionals in front of those with mental health crisis, and then they can make the appropriate mechanisms for their long-term care, as well as just make that connection. And then now we actually have local, I would say, people that rely on us often. We use the term frequent flyers, but they are people that are in need. They call for us often. And it's no longer something that law enforcement needs to take the lead in dealing with, unless it's obviously escalates or something that's a little out of control. But that frees up our law enforcement brothers and sisters to serve their community in that capacity, and it also puts the professionals at the doorstep of those that are really in need on the mental health side.
Nader, same question to you. I mean, you come at this from so many different experiences. I imagine you can't answer, you don't have just one thing you'd like to fix, but probably several.
Right. I think, it's very nice to have the support of the administrative side of your facility. And when it comes to mental health and providing the needed mental health to frontline health care providers, I think that needs to start from the very top and with the administration. And there's been a lot of positives. There's been a lot of things that have happened as a result of COVID. And one of the things that I think is happening, and we've instituted it in our hospital recently, and I know it's happening across the country, is just like in the C-suite, we have a chief executive officer or a chief operating officer or a chief medical officer. Now we have a chief wellness officer. And I think that, at least as a point of contact, provides the infrastructure for us to be able to recognize who's in need and to be able to actually provide the resources for the facility to provide that mental health. As a leader on the medical side, I recognize what my staff were going through, but I didn't have the resources availed to me to provide them with the help they needed. Now, with more and more institutions, including ours, actually having chief wellness officers and them having a budget for that, I think that will hopefully bring about some of the change from an institutional perspective that will provide our healthcare frontline workers with the mental health services that they would benefit from.
Taryn, when we were talking, I think you had some really interesting insights about this sort of idea of burnout and the way that institutions that you've worked for have kind of framed that as almost like your responsibility, right? Can you talk about that and then, sort of also what you would fix? You're going now to about to enter a PhD program that sort of is dealing with some of these kinds of systemic issues, right? And that you're hoping to be able to kind of apply that knowledge. So, I'd be interested to hear what your thoughts are on that too.
Thank you for that question, Pam. I am really hoping to change the narrative on burnout. In my experience during the pandemic and even before the pandemic, it seems to be framed by the hospital organizations I've worked for as a lack of self-care or some sort of a personal thing that, you need to be taking care of yourself outside of work, you need to be doing X, Y, Z, and that's why you're not happy at work. When really I think we need to look at the work environment as a major determinant of health, and no matter how many massages I get or how many meditations I do or how many miles I run, if I'm going into a chronically under-resourced work environment, that trauma is an innate part of that work environment. I am an emergency nurse. I experience vicarious trauma every day. Workplace violence may personally impact me directly with trauma. The answer to that is not self-care, and especially during the pandemic, I just saw that narrative pushed on nurses so aggressively, and it's really become a trigger point for me, and kind of a painful point as well. And I think also it's just an oversimplification of multiple things that frontline healthcare providers experience. So, you know, you have moral harm on a spectrum. There's moral distress to moral injury. When you have these beliefs or these oaths that you take as a provider, and then you cannot act on them because of systemic restraints or resource restraints. There's the vicarious trauma, there's direct trauma, there's all different types of nurse-specific traumas. But to just say that that's burnout, it's not addressing the issue. Let's call this what it is. This is trauma and all sorts of forms of it. So then how do we treat that? And how do we get those resources to our frontline healthcare workers, despite the stigma, despite the lack of resources? EAP is great, and I won't ever knock that, but that's also coming from the system that is often the source of your trauma. So you're asking a victim to go to a perpetrator, in a sense, to get help, and I've seen that really backfire on dear friends of mine, and leave them very scarred. So I think, you know, I think it would be a better investment of healthcare institutions' time and resources to consider trauma-informed cultures and trauma-informed organizations. And I think this is a relatively recent portion of the conversation around COVID, but, you know, leaders at all levels in the healthcare institution, and I loved what you were saying about having a chief wellness officer. All levels of leadership, executive to mid-level managers, need to understand trauma. They need to be aware of trauma, but then they also need to know how to interact with their employees directly when they're experiencing it, real time, and model that for them. That's really important, and I don't know how we're going to psychologically recover as healthcare workers apart from that, because that is what COVID the past 2 years has been, is trauma in multiple forms. And to address that, then we need to look at trauma interventions, and we need to have supportive cultures that understand and can facilitate that recovery.
Thank you. You know, all of you have mentioned misinformation, and I'm actually just curious, what helps, you know, get people who are, say, making conclusions about their health or decisions about their health that are not, that are contrary to what the science says, like vaccine hesitancy. What helps correct that? That's something I think, I've been just kind of astounded by how widespread vaccine hesitancy has been in this climate and how varied it is, the underpinnings of it. And I guess I just wondered whether is there anything that you all have found that works, because providing correct information doesn't always work, right? And all of that is sort of a huge source of all the stress that we're talking about. So I don't know if Gabe, if you have any thoughts about that, but.
Well, yeah, in particular, I do. I think Travis could attest to this. I think firefighters are looked upon to be tough. Okay, we go on a critical run, and then we just forget about it and move on to the next call, the next call, the next call. So they'll internalize it. And I've actually gone to our department. I would like a system where as soon as a tragic event happens, I could put them not available. And we're fortunate enough to have a mental health, a psychiatrist and division where they speak to someone and they make sure everything's okay. So any critical event I go on, I actually ask the members. I'll put them not available. Hey, are you okay? You want to talk to someone? Because we have the services for that. So that's in particular what I would like. And then I try to be the leader out there. I'll set the example as being in leadership. Hey, I was part of the COVID division for the vaccination. I was one of the first ones who got it on the first day. I couldn't wait for it. So I saw what was out there. So I was trying to push that out to my crew members so they knew exactly what was going on and how this could benefit them. I think just by being the leader and giving examples, you hope that the members will follow your lead. So that's how I try to put my point across.
Okay, thank you. Travis, do you have any thoughts on that?
Yeah, and if I understand the question, you're asking what what we may suggest to change the narrative to have more buy-in in dealing with COVID?
Yeah.
Okay.
And
the
then
misinformation, how that's associated with it?
Yeah, and having people do less
Very good. Muzzle it.
self-destructive.
The misinformation is a driving force for me personally, a very frustrating component to my world, and I'll just give you an example of that. When we go to a home that is full of unvaccinated, and this isn't about vaccinated or unvaccinated, unvaccinated family members, that I am standing before them, asking them, my patient is altered to the point where I need somebody else to give me the right to take them from their home. Okay, there's laws that require me to receive that type of permission in a sense. When I have a patient that is in that much distress, and more than likely COVID related based on our assessment, when we walk down that path, the family members are not interested in supporting a transport of a patient due to a political issue, due to the misinformation that they've received. And I've also been told by a doctor at one point in time at the receiving facility when I turned over a patient that the patient was reluctant to receive care, and now he's going to to prepare to intubate this patient who was severely affected by COVID. He said that the patient wouldn't come in because basically the narrative that they were receiving on the screen. They didn't want to listen to their own PCP, their own personal physician that advised them weeks ago, you need to go to the hospital. So the misinformation, you can see the long-term implications of that has drastic consequences. So I would love for us to figure out a way to filter the misinformation that our communities receive.
And Nader, were you able to, did your wife ever get vaccinated or?
No, but that's a separate issue. Yeah, I mean, first of all, I commend you for all the work you've done. I mean, you are in essence kind of the kind of individuals that we need more of in our society as journalists that really disseminate correct information. So, kudos to you and all the work you've done, and all the speakers who personally suffered and are raising awareness. I think that says much more than even community-based, physicians going to having community organizations have physicians talk to patients. I think it resonates more when it comes from the patients, from a microcosm of the actual hospital and when patients do come in, because in the end that's kind of the world I live in. What I think has helped has been allowing family members now back in. I know Dr. Eli earlier mentioned that. I think most institutions are allowing family visitation now, which I think was a mistake. We all thought it was a mistake when it was happening, but fortunately that's happening now. Aside from providing that second essential component to someone's well-being, the mental wellness is having love, support, not just from the providers, but from their own loved ones. I think for the loved ones to actually see with their own eyes what their family member is going through, I think resonates more than anything. When we deal with end-of-life discussions, which we do on a daily basis, unfortunately multiple hours, it makes so much difference when we're having those discussions in person, and for family members to have been a witness to their loved one suffering for days and days, and with us repeating that message, it begins to resonate. It's a combination of us informing them, but also them being a witness to what their loved one is enduring that really works. And so I'm at least glad that that is happening, and family members are able to come in and be with their loved ones.
Yeah, that's a really perceptive point that I hadn't really thought of exactly that way, that it's not only family members are not only providing very important emotional support, but often they are able to be a kind of communicator or an intermediary between the health providers and the patients.
And like Travis said, they actually, those people very often in, for example, unvaccinated families, they can take that information back to all their family, most of which probably are on the same page, and describe to them, from a personal perspective, what their loved one is enduring, and hopefully that will slowly change some minds. And at least that's one component that I think can go a long way.
Oh, that's great. Well, I think we can maybe take a couple questions if anybody has one.
I'm going to remove this because I'm a little short. Hi, I'm Giselle. I work with Verily Life Sciences. Some people might not know that name, but you might recognize Project Baseline, which is one of the many COVID testers out here in California and across the U.S. Specifically, I work on the Project Baseline side, actually. So, thank you, everybody, for speaking, and all the previous speakers. Everything has been very insightful and moving. I come from the research side of Verily Life Sciences, so what's really interesting to me is hearing, firsthand healthcare providers who are having to battle probably the other biggest enemy in this entire pandemic, which is misinformation. Coming from the research perspective, I'm curious, as you've treated so many patients and then you've had to, obviously deal with so many people not understanding not only what they're going through, especially to have, firsthand experiences here, not understand what they're going through, number one. Number two, having to sort of counsel them and try to convince them of the sanctity of your profession and of truth. I'm wondering if any of you have had experience with directing some of your patients to research. And the reason why I ask that is, of course, with my line of work, I'm thinking about the funnel here, right? And how participants are finding. We specifically have a COVID research project community. It's basically a registry of over 200,000 participants, who are regularly informing the future of COVID research. And we're, not the only ones out here doing this, but I'm curious, because you're the ones who have sort of the most, in my eyes, power or potential. You're our best lead to getting more participants to join research so that we can better understand and inform and help other people have validation for their experiences. So I'm curious, your individual experiences, if anybody if you've known of ways to sort of direct patients to research or being a part of research.
Thank you. Whoever would like to tackle that, please go ahead.
I can, I guess. By the way, thank you for the research that you do and the work you do. That's a great question. We actually do have patients, and one of the problems, as many of you know, with a lot of our therapeutics, at the very beginning, we didn't know what we were doing. That's the reality. I'm sure those of you who are healthcare providers can attest to that. We really didn't know. And a lot of the data initially was shaky at best, but we did what we could. We used corticosteroids, we used antivirals, which largely didn't do much. At the beginning, we tried the Plaquenil, and more, we've accumulated data, and I think every institution has responsibilities, particularly larger tertiary care hospitals, including ours, to actually do that research. So we do enroll patients certainly in the acute setting for different trials. For example, we were part of many trials looking at biologics, various biologics or disease-modifying agents in COVID. Certainly, I know there's a lot of trials on more of the chronic COVID patients and different therapeutics that we're running. But certainly, I think we have that responsibility to ensure that our patients are routed towards, at different stages in COVID, to the appropriate kind of facilities that can provide for them to be enrolled in research trials, so that the larger community can ultimately benefit from some of that data. That now we're gaining more and more insights. But again, just to go back to some of the concerns or skepticism that the community had at the beginning, largely didn't know what we were dealing with. We were dealing with a virus that behaved so differently than any primary respiratory virus than we'd ever dealt with. I remember telling my medical students that at the beginning, who later got pulled off the rotation, that I feel like we're on the same page for the first time. I just have more tools in my toolkit, but we're just kind of learning as we go. And I think research is quintessential to allowing us to have the appropriate data for us to be able to use for our future patients. So I hope that partially at least answers some of your questions.
All right. I think there's one question. Do you want to come to the microphone? We have time for one more.
I'll make a comment to both of you on this and answer as if I'm asking a question. It's about disinformation, and I see it all the time because I don't block people on Twitter feed. It's important to me to see radical, wrong ideas that are out there because it's the only way you understand what's occurring in the world. And rather than getting rid of disinformation, even 2 years into the pandemic, the disinformation is larger and greater than ever. So what people who make disinformation happen is do something like, disinformation is based on kernels of truth, and that's the reason that it's so powerful, is that it appears to be truth. So those of us we know, those of us who are reasonable know that scientists are learners and that they take in new information daily, weekly, and they keep adding to their information, and that that's not a failure, that that's a strength. But disinformation people take, for example, what you said a moment ago. We didn't know what we were doing. So they'll take a photo of you, they'll make a meme, and it will say, your picture blown up, and it will say on the bottom caption, "We didn't know what we were doing." And they'll take, they're not lying, you actually said this. So those of us in this room understand that you're not saying it to show weakness, you're showing it to say, we have been learning all along, and this is the progress we have made. This is what we know now. The disinformation spreaders will take that kernel of truth or other kernels of truth from other people in the medical field who are high up. And so even though I didn't ask a question, I would answer it as if I'm asking a question.
All right. Quickly, if either of you or any of you want to say something quickly to that, I think you make a very good point. But
I'll just be careful what I say moving forward. But no, you're absolutely right. But I think, again, we're learning as we go. We're constantly reviewing the most recent peer-reviewed literature, and we're practicing evidence-based medicine as best we can. But at the same time, we have the responsibility to care for our patients as best we can with the resources we have and with the information we have at hand.
Thank you, everybody.
all right.
Quick lunch break, and then we'll be back. Thank you so
Okay.
much. Thank you.